The pharmaceutical companies, again, they absolutely will charge, thousands of dollars for medications that only cost pennies to make. And the PBM will absolutely ratchet up the additional cost that the medication will have because they're adding that transaction fee on top of it. And so when you put the two together, there is coupability to go around.
Welcome to another episode of Endocrine Matters. I'm your host, Dr. Arti Thangudu. Today, we're diving into one of the hottest and most contentious topics in healthcare, the pricing of GLP-1 receptor agonists like semaglutide. You might know them as Wegovy and Ozempic, and also tirzepatide, branded as Mounjaro and Zepbound. These groundbreaking medications are transforming the landscape of diabetes and obesity care, but their costs are raising serious questions and challenges for patients, providers, and employers alike. Joining me today to unpack this issue is Dr. Eric Bricker. Dr. Bricker is a physician turned healthcare educator and a renowned expert in dissecting the complexities of the U.S. healthcare system. He's the voice behind the incredibly insightful A Healthcare Z videos, where he takes the opaque world of healthcare finance and breaks it down into digestible, actionable pieces for all of us. I'm thrilled to have him here today and to help us understand the many layers contributing to these sky-high drug prices. One critical player in this conversation is the Pharmacy Benefit Manager, or PBM. PBMs are third-party companies that act as middlemen between insurance providers and pharmaceutical manufacturers. They control prices and availability and dictate what is on our insurance plan's formulary, aka what medications are covered by an insurance plan. This can cause patients and employers to spend more on medications. Recently, PBMs have been in the spotlight due to allegations that they inflate drug prices. In September 2024, the Federal Trade Commission, FTC, filed lawsuits against three of the largest PBMs, CVS Health's Caremark, Cigna's Express Scripts, and United Health Group's OptumRx, alleging that they created a perverse drug rebate system that artificially increased the price of insulin and marked up the price of specialty generic drugs at their affiliated pharmacies. The FTC report found that these big three PBMs control about 80% of U.S. prescription drug sales. These PBMs are not standalone entities. OptumRx is part of United Health Group. Express Scripts is part of Cigna, and CVS Caremark is part of Aetna. While the Pharmaceutical Care Management Association, the trade group representing PBMs, has denied these allegations, the lawsuits highlight just how significant a role PBMs play in determining drug costs. A January 2025 report from the FTC added even more insight, revealing that the big three PBMs generated over $7.3 billion in revenue by significantly marking up specialty generic drugs. The FTC analyzed 51 specialty generic drugs from 2017 to 2022 and found that PBM-affiliated pharmacies charged prices substantially higher than the national average drug acquisition cost, which estimates the cost for pharmacies to acquire a drug. For example, the multiple sclerosis drug dimethyl fumarate, which costs pharmacies approximately $177 for a 30-day supply, was billed at nearly $4,000 on average by PBM-affiliated pharmacies. Oncology drugs were sometimes marked up more than 1,000%, while HIV and transplant drugs saw markups between 100 to 1,000%. These findings highlight how PBM practices significantly increase drug costs for patients and the healthcare system as a whole. We'll cover key questions that I know are on many of your minds. Why are these drugs so expensive in the United States compared to other countries? What role do pharmacy benefit managers, or PBMs, play in driving up costs? Is it the pharmaceutical companies, the insurers, or someone else entirely who's responsible? And most importantly, what can we do as providers, patients, and employees to be good stewards of our employer-sponsored health insurance plans? This episode is especially relevant for those of you who are clinicians navigating how to balance cutting-edge care with the financial realities your patients face. And for employers and HR leaders listening in, we'll touch on balancing benefit structures that maximize access to these life-changing therapies without breaking the bank. So buckle up, friends, and let's get into it. Hello, today we have Dr. Eric Bricker, one of the most amazing people in healthcare finance, I think, today. I have learned so much from him and his YouTube videos. They are crisp, short, and to the point, and are so educational on this very, very important space that more people in general, but definitely physicians and patients and employers need to learn about. So Dr. Bricker is a healthcare finance expert, but first he's a physician, and I think he marries the two very, very well. And Dr. Bricker, before I go on and rave about you, can you tell us a little bit about yourself and your story and kind of how you got into this space?
Well, that was a super nice introduction, and thank you for having me on Endocrine Matters, and thank you to everybody for listening. I'm not sure I can live up to that superlative at the beginning, but I'll try. But as you said, I'm a doctor. I'm an internist, and I originally, initially out of college, started out as a hospital finance consultant because I don't have any doctors in my family, and this was back in the 90s. And every doctor I talked to said, "Whatever you do, don't become a doctor," because the billing and the government, the insurance companies, they've ruined the practice of medicine. So I wanted to learn about that, and so then decided I still wanted to be a doctor. So went on to the University of Illinois at Chicago for medical school, and wanted to somehow combine what I had learned during my hospital finance consulting with the practice of medicine. So I wasn't exactly sure how that was going to happen. But then I went on to Johns Hopkins in Baltimore for residency in internal medicine because Hopkins does a ton of policy work. And I'm like, okay, well, maybe be academic physician and work on healthcare policy. But it turned out that I'm a little too impatient for healthcare policy research. I needed to see the fruits of my labor a little faster. So I actually started a healthcare navigation company with one of my consulting colleagues while I was in residency. And he was based in Dallas. So I moved from Baltimore down to Dallas as soon as I was done with my residency. And this was during the great financial crisis. So we tried to raise venture capital and failed miserably. So we're like, well, we're just going to keep our job. So I was working as a hospitalist. And then, nights, weekends, we were working on growing this business with a third partner. And eventually it got to the point where we would sell to employers to help their employees and their family members navigate their health insurance and healthcare. Sort of think of like a travel agent, except for healthcare. We would make zero clinical decisions. But when it came to all the paperwork, whether it was the prior authorization or the scheduling, or if you got a problem bill, then we would help resolve all that for you. So sort of your healthcare ninja, if you will. We called them health pros. And we grew that to about 2,000 employer clients, about 1.8 million people that we supported, had McDonald's, Southwest Airlines, T-Mobile, a whole bunch of large corporate clients. And then we sold that business in 2018. And then I wasn't beholden to anybody. So I started making these A Healthcare Z videos because I'd seen kind of the doc and the hospital and the insurance side. And I could kind of, shoot people straight in terms of what I had seen. And that's what the A Healthcare Z videos are. So anyway, that's much more of an answer than you wanted, but I'll pause there.
No, that was amazing. And I think one thing to take away from that is that you ran with this curiosity and you went further to engage with that curiosity. And it wasn't just like, you're like, oh, I wonder what this is like. And then you stopped. And I think that's something that is so important for us to see how that can change not only your life, but many individuals' lives. You said 1.8 million people. So that's incredible. The other thing that I think is crazy about that is I think we're past this now, especially given the state of the country and the news cycle. But many people think that insurance is there to help them, health insurance. And then here you were creating a company to help people understand or navigate a system that was actually, that they think is supposed to be there to help them when they are in their most vulnerable stages in their life, when they're sick and their families members are sick. Have you thought about that in a way, or have you thought about how that's a little, I don't know, a little crazy, or not crazy, not that you're crazy, but it's kind of crazy that this system that's supposed to be helping needs another entity to come help people navigate that system.
Oh, yeah. And to make it even crazier, one of our competitors was this company called Health Advocate out of Philadelphia. And the founders of Health Advocate were the executives from a former health insurance company called US Healthcare. So way back in the 90s, Aetna bought US Healthcare, and those executives then left. And they're like, oh, yeah, it's so messed up. We know exactly how to help people. So we're going to start a separate company to help people solve the problems that in part we created. So we were not the only people to come up with this idea. And it is, and interestingly, a lot of the health insurance carriers have then subsequently started their own navigation and advocacy services, because most health insurance carriers don't want employers using outside vendors. They're like, well, just come to us and we'll provide you all their services. So you can actually buy additional navigation services from a health insurance carrier to help solve, to your point, many of the problems that they themselves create.
It's an incredible business strategy, really. Let's create a bunch of problems for people and then help them solve it. So one thing that I really wanted to dive in, and just so you know, a lot of our listeners will not know that much about the healthcare system as far as what a PBM is and those types of things. So with your answers, just be mindful of that. And I might ask you to backtrack and say, wait, define that. But I would love to talk about why the heck are these GLP-1 receptor agonists, Ozempic, Mounjaro, Zepbound, Wegovy, why are they so expensive in the US? And as a comparison in other countries, they may not be so.
Yes. So in America, we obviously have patent protection, so that once you create a new medication, you have the exclusivity in terms of being able to sell it on the market. So essentially, you're sort of given a monopoly for that particular drug. Now, on the opposite, I'm gonna use one fancy economic terms, and then I promise I won't use a fancy economic term ever again. But the opposite of a monopoly is a monopsony. Monopsony, and a monopsony is not when there's one supplier, but there's one buyer. And so in places like Europe or any country that has a universal or a state-run healthcare system, then they have a monopsony. There's only one buyer of healthcare. It's the government of the UK, or it's the government of France. And so there, if a pharmaceutical company is the sole maker and distributor of a particular drug, well, then the people in the UK or France or whatever other country are going to be like, fine, if you want to sell it in the UK, we're the only people who are going to buy it. Nobody else is going to buy it. And in America, we don't have that. And not only do we have lots of individual purchasers of healthcare, but up until just recently, it was actually the law in America that the huge purchasing power that Medicare has cannot set pharmaceutical prices. In other words, the federal government in America cannot act as a monopsony. And the Biden administration has started to change that a little bit, where there's just a handful of drugs where they have actually done price fixing on, and it hasn't even taken effect. And all these GLP-1 medications are not on the list of these medications that the government has set the price on. And so anyway, I'll try to keep the answer short, but that's why the GLP-1s are so much more expensive in America than they are in other countries.
So do you think it's the pharmaceutical companies, or do you think it's middle people like PBMs? Why do you think that here in America, there seems to be no limit to how much these medications can cost?
Yeah. So it's a good question. And so you got to understand the motivation and the responsibility of a pharmaceutical company. So Eli Lilly and Novo Nordisk, the two pharmaceutical companies that make these GLP-1s, are publicly traded companies, and they have, what is, quote unquote, a responsibility to their shareholders to make as much money as humanly possible. So they are profit maximizing machines, and all their shareholders are like, and their shareholders are, maybe, Joe and Jane, but it's also large pension funds and insurance companies. And those investors are like, look, this is true for any stock, whether it's stock in Walmart or stock in anything. It's like, look, your job as a company is to make as much profit as humanly possible. And so when those companies sell pharmaceuticals in America where they have patent protection and exclusivity, then frankly, it is their responsibility to their shareholders to charge as much as humanly possible. Because if they didn't charge as much humanly possible in America, the shareholders would be like, what gives? You said you were going to maximize your profit here, and here you have a country like America that is not a monopsony and does not do price controls, so you better jack up the price. Otherwise, there's no way I'm going to own your stock and I'm going to sell it. And so it's at the end of the day, that then becomes the issue of, okay, if you're going to have publicly traded pharmaceutical companies whose sole purpose is to maximize shareholder returns, then all you're going to do is expect them to act within the rules and the confines that they have been acting. So any rational person within a pharmaceutical company is going to charge as much as humanly possible in America.
And what's the role of PBMs? And could you start by telling us what a PBM is?
Yeah, so in order for the third party, the insurance company, the employer, or the government, to pay the claim, then there's actually claim payment companies that process those transactions. You can think of them like Visa or MasterCard, right? So the government and the insurance companies aren't going to go around like literally with like trucks full of cash to the pharmaceutical company, right? It's going to be an electronic transaction. And pharmacy transactions are the reason why historically health insurance companies haven't processed pharmaceutical claims is because pharmaceutical claims are very high volume. Right, you think about I think it's 2/3 of Americans are on some sort of a medication, right? So it's just, gobs and gobs of transactions. And so historically, there were separate companies, these PBMs, that were very good at processing this very high volume of transactions. They would have essentially all like the Visa terminals, like the credit card terminals at all the different pharmacies. And they would be able to process all those transactions and then take all the money from the pharmaceutical companies and then give it to the pharmacies, who then would take that money and buy the pharmaceuticals from the drug makers. So it is purely a transaction, a financial transaction service similar to Visa and MasterCard. Now, those used to be separate businesses from the health insurance companies, but those PBMs would take just like Visa and MasterCard take a fee, those PBMs would take a fee. And that fee was so lucrative that the big insurance companies, so like Optum bought a PBM, or excuse me, United bought a PBM called Catamaran, and then they changed it to Optum. So now United owns a PBM. And CVS bought a PBM called Caremark, and that's called CVS Caremark. And Cigna bought a PBM called Express Scripts. And so now Express Scripts is so all the health insurance companies actually own the PBMs. And Blue Cross was like, hey, we need to get in on this PBM stuff. So they actually even started their own PBM that a lot of the Blue Cross plans share, that's called Prime Therapeutics. So today, there are no large, in those top 4 PBMs that I just mentioned, they control about 70 to 80% of all PBM transactions, and all of them are owned by large health insurance companies. So it's important. So we use this term PBM like it's this separate thing, but it's really not. It's just part of the health insurance company that processes the transaction. And when they do, they take an additional fee for processing that transaction. And, typically Visa and MasterCard have it's like, I think 3 to 5% is what they're charging as sort of that extra fee. And sometimes the PBM is charging a lot more, as in, 30, 40, 50% for, depending upon the drug. They're charging a lot more for that transaction, which is why oftentimes the PBMs also get blamed for expensive drug costs in America, because for some of those medications, they're only adding an additional like penny transaction fee, but for others, they're adding hundreds or even thousands of dollars.
So, are PBMs supposed to be responsible for figuring out what is on a formulary for a certain insurance plan and for negotiating drug pricing for that particular plan?
Yep, so that's a great question. And the short answer is the PBM actually determines the formulary. So when they, to continue the analogy, you can think of like Visa or MasterCard as like being responsible for negotiating the prices at like Walmart and Macy's. Okay, so instead of instead of Walmart and Macy's just setting their prices however they want, it's like the credit card companies went out and like, okay, Walmart, what are you going to charge? And Macy's, what are you going to charge? And so, and also it's like, okay, the formulary is okay, well, there's only certain things that you're going to be able to buy. You're only going to be able to get shoes and this brand of milk and this brand of blankets and this brand of cereal. And so that the PBM is actually negotiating not only the prices, but they're also negotiating what you can or cannot buy from Macy's or Walmart. And in this case, you replace Macy's and Walmart with the pharmaceutical company, Merck or AstraZeneca or Eli Lilly or Pfizer. And so not only is the PBM charging the transaction, but they're using that leverage that they have to be like, okay, if you want to even, let's say Walmart really wants to sell their milk. Be like, okay, fine, Walmart, if you want to sell your milk, like, I don't know, there's lots of other places we could get milk. We could get milk from Kroger. We could get milk from Safeway. Why should we have Walmart milk? And we're like, okay, we'll give you a good deal on the milk. We'll sell it to you for X amount. And they're like, okay, but then we need to add on an extra, the milk you're selling for $5 and we're going to add an extra $3 onto that milk in order for you. But like Walmart's like, well, we don't want our milk to be expensive. We want to sell our milk for $2 and we want you to only add 50 cents. And they're like, look, if you want to be on our formulary, you're going to sell your milk for $5 and we're going to add $3 to it. And there's going to be $8 milk. And so people are like, well, milk, $8 is a lot of money for milk, right? And so the pharmaceutical companies blame the PBM, be like, look, we wanted to sell the milk for $2, but you wouldn't let us sell the milk for $2 because you wanted to jack up the price and take $3 for yourself. So there's a whole bunch of finger pointing, okay? Now, the pharmaceutical companies, again, they absolutely will charge, thousands of dollars for medications that only cost pennies to make. And the PBM will absolutely ratchet up the additional cost that the medication will have because they're adding that transaction fee on top of it. And so when you put the two together, there is coupability to go around.
Do you happen to know, and you may not, but what the cost to make Ozempic or Mounjaro is?
Well, to a certain extent, you can use the compounding prices as a proxy, but it is single-digit dollar amounts, if not lower. And the pharmaceutical companies freely admit this. They're like, look, it's not expensive to make, but what they say is that we have huge sunk costs in the research and development of the medication. So yes, it might be super inexpensive to manufacture. And so the marginal cost to create an extra vial of Ozempic might be very low. However, we are justified in charging these huge amounts in order to recoup the research and development that we did. And so that, we're not here to answer that question today. And I think the sort of poster child for this is like rare orphan disease drugs, like for things like cystic fibrosis where it's hundreds of thousands of dollars a year to treat a person with cystic fibrosis, or some cancer treatments for brain cancer are literally $500,000 a year. And of course, it doesn't cost $500,000 to make that medication. And to what extent is it extortion on the part of the pharmaceutical company? And to what extent is it them, quote unquote, advancing medical research through this money that they're making? And the short answer is, it's a highly controversial topic.
That's it for part 1 of this conversation. If you're enjoying the discussion, be sure to tune in for part 2, where we'll continue the conversation and go even deeper. Make sure you're subscribed so you don't miss it.